Welcome back. Now, in this part, regarding the discussion of fluid and electrolyte management of any patient, the basic points we were discussing. Let's go to this part, and in this section, we are going to study basically how we usually classify the various body fluid changes that may occur. So, regarding this topic, as far as the fluid balance disorders they are concerned, there are three scenarios possible. Either the disturbance can affect the volume, the total volume of total body water. To be more specific, initially with extracellular fluid volume, or it can disturb the concentration of various ions, and especially the sodium ions, that is very closely related to the total body water volume. And finally, the third scenario could be it may disturb the composition of body fluid. The various examples could be like the movement of intracellular ions, and you know already the most important cation intracellularly is potassium, right? K plus. So in disturbances of composition, we will discuss in the subsequent video lectures or interactions regarding hypokalemia or hyperkalemia, hypercalcemia or hypocalcemia, and other electrolyte disorders. Whereas in disturbances of concentration, we'll discuss the hyponatremia and hypernatremia. In volume disturbances, we are going to discuss the volume deficit. What is the effect of this volume deficit? And on the other hand, volume excess, what is the basic effect, or what are the effects of volume excess? This volume deficit or excess primarily affects the extracellular fluid volume. Okay, so I've just given you this scenario, the summary of these three conditions possible. So body fluid changes can be classified in these three varieties: the disturbances in volume, disturbances in concentration, or disturbances in composition. In this video, we'll just restrict ourselves with the basic concept of disturbances in volume. Later on, we'll go through these three, the other two classification. Now the important thing is these three disturbances, the three types of disturbances in body fluid environment, they may occur simultaneously. These three important basic points regarding three classification may occur simultaneously, having unique mechanism, separate unique mechanism. All of these, they may have unique mechanism, may occur simultaneously, and that's why they require individual correction. So we'll have to focus on the volume changes also, as well as the concentration changes, as well as the composition changes. So these three concepts are very important: volume change, concentration change, and composition change. In volume change, deficit or excess. Deficit means whenever patient is having less intake, or when a patient is losing more, like in diarrhea or vomiting due to any cause. Excess means whenever the patient is hyperinfused, knowingly or unknowingly, or whenever kidney is not properly functioning, there is water retention. Disturbances in concentration is reflected by the serum sodium levels. So remember it, disturbances in concentration means something related to sodium levels. It may be high, hypernatremia, it may be low, hyponatremia. And finally, the composition. The composition means only the composition is being changed, no effect on volume or concentration part. Or sometimes all the three can exist together. In composition, something related to potassium levels or other cations and anions levels, right? So simultaneous occurrence may be there, each having a separate entity with unique mechanism. So they require individual correction. So we must focus individually on these three different routes of body fluid changes. So let's go with the changes in volume first. Changes in volume first, we are discussing here. Whenever there is isotonic gain or loss of salt solution, means suppose some patient is being infused with 0.9% sodium chloride, isotonic gain. Only extracellular volume is being changed and almost the intracellular fluid volume is unaffected, not disturbed. So whenever isotonic gain is there or isotonic loss is there, isotonic losses means a mild GI loss. Usually GI secretions they are isotonic or slightly hypotonic. So in mild variety of GI loss, there is only change in the extracellular volume. And that's why these patients are not presented to us in serious conditions clinically. So isotonic gain or isotonic loss of salt solution affect only the extracellular fluid. Okay. Now if suppose the free water is being added or lost from extracellular fluid, that GI loss is getting worse, and now free water is again being lost along with the other ions, or if the patient intake is too much regarding the free water, only water, free water is being added here, in that case scenario the water movement will start. Water movement between what? Between ECF and ICF. Till when? Till the osmolarity of ECF and ICF becomes almost equal. So very strictly monitored. So there is free movement of water is there. If there is any effect over the extracellular fluid compartment, it will be compensated initially with the movement of water between ECF and ICF. Very important point here. Now, the important thing regarding the ions other than sodium is that concentration of most ions in ECF can be altered without change in osmotically active total number of particles, and that is not the case with the sodium. So we can change the level of potassium without changing the osmolarity of that particular fluid. There is only a compositional change. Whereas in sodium case, usually if we are going to change the concentration of sodium ion, the scenario will be reversed. There will be a concentration change. But if we are going to change the potassium, there is only compositional change. So suppose example, if we are going to double the serum potassium concentration, there is profound alteration in myocardial function without altering volume or concentration of fluid spaces. We can affect the myocardial function. That's why in cases of hyperkalemia, there is risk of heart failure, right? Improper functioning of heart is there in case of hyperkalemia or even in hypokalemia or in cases of hypercalcemia. There is cardiac chances of cardiac arrest, right? Some in systole, some in asystole, diastole. That is a different discussion. We'll discuss this thing also in future videos. So the take-home message for this slide is we can change the serum potassium level, we can change the serum calcium level without altering the volume or concentration of ECF or ICF. But we cannot change the serum sodium level without changing the volume or concentration of fluid spaces, right? Second take-home message, change in sodium ions means change in concentration, while change in potassium or calcium ions is just a compositional change, right? Okay. Now could be two scenarios. The extracellular fluid volume could be deficient. It could be possible to have a less of ECF, or another scenario is more of ECF. So extracellular volume, when deficit is there, and this is the most common fluid disorder in surgical patients, the loss is there, the ECF is less. The causes could be various, but broadly speaking, the volume deficit could be acute in origin or chronic in origin. Now, how the patient of acute volume deficit is going to present, and how the patient of chronic volume deficit is going to present? What are the various differences? So the common thing is both the types, the acute as well as chronic volume deficit, both the patients, they present with cardiovascular system signs, you already know that, and CNS signs, central nervous system signs. But the basic difference between acute volume deficit and chronic volume deficit is presence of tissue signs like decrease in skin turgor pressure along with presence of sunken eyes. These two signs are present in chronically deficit cases. The chronic volume deficit cases, the tissue signs as well as sunken eyes are also present along with CVS and CNS signs. Very basic difference. Now, during the laboratory examination, if there is volume deficit and if the volume deficit is severe, there will be elevated blood urea nitrogen. And why there is elevated blood urea nitrogen? Because due to volume deficit, there is reduced glomerular filtration rate, and finally the patient is also having the hemoconcentration due to volume deficit. So blood urea nitrogen on laboratory examination, it is raised. In patients suffering from volume deficit disorders, the urine osmolality is usually higher. Why higher? Because kidney is conserving water to counteract the volume deficit. So urine osmolality is usually higher than serum osmolality, right? Usually in these conditions, the reabsorption of water is being taking place in the kidney. And in these patients, urine sodium will be low. Why urine sodium will be low? Because the sodium will be conserved by the body through the kidney. And why the body wants to conserve the sodium? Because the sodium, along with the sodium, water will move in and it is going to balance the deficit in volume. So urine sodium will be low. And most of the cases, it is less than 20 milliequivalents per liter, urine sodium, right? Most of the cases, the serum sodium concentration does not strictly reflect the volume status. I am using the word strictly. Sometimes it may give some idea to us regarding the volume status, but strictly it cannot be correlated with the volume status, the serum sodium concentration. So it could be high or normal or low, the serum sodium levels, even when a volume deficit is present. The values could be high, normal or low. There are various causes. We'll come to that. Okay, volume deficit is there. But what are the causes that is presenting to us with high serum sodium even in presence of volume deficit? What are the causes when the serum sodium levels are normal but volume deficit is there? And finally, what are the causes where serum sodium concentration is low when a volume deficit is present? Most common causes, if you're talking about the most common cause of volume deficit in surgical patients, the cause is loss of GI fluids. And loss of GI fluids through which route? Through most of the patients in surgery wards or in the post-operative period or even in the pre-operative period, they are on Ryle's tube suction or nasogastric suction. So continuous nasogastric suction or drainage may lead to loss of GI fluids. Vomiting may lead to loss of GI fluids. The diarrhea, again loss of GI fluids. And enterocutaneous fistula, there is a communication tract between the skin and the intestine. One of the example, yes, could be the divergence, the ileostomy, the colostomy. So even in these cases, there is loss of GI fluid. Volume deficit is there. Okay. Sometimes the isolated sequestration due to various conditions may lead to volume deficit, like whenever a patient is having soft tissue injuries and there is collection there, or in patients of burns, or in patients of intra-abdominal processes like a patient of peritonitis, a patient of intestinal obstruction, there is third space loss, or a patient during and after the prolonged surgery, they can lead to massive volume deficits, right? The second scenario could be the volume excess, where the extracellular fluid volume is in excess. Usually, there are various reasons. It could be iatrogenic, or it could be secondary to renal dysfunction if kidneys are not functioning well, or if the patient is suffering from congestive heart failure, or if a patient is suffering from cirrhosis. Cirrhosis could be due to various hepatitis virus infections, hepatitis B or hepatitis C, chronic basis, or alcoholic liver disease can lead to cirrhosis. And other causes of cirrhosis are also there. So in these cases, there could be extracellular volume excess. The kidneys, they are not being able to excrete the excess water. CHF, low GFR, again excess volume. Cirrhosis, lot of ascites, third space loss is there. But in these patients, there is extracellular volume excess, right? Both plasma and interstitial volumes usually are increased, and symptoms of these patients, they are primarily related to the pulmonary part and the cardiovascular part. The various symptoms and signs related to these systems you already know. If a patient is fit, healthy patients, even the edema resulting due to excess of volume or the hyperdynamic circulation effects, they can be very well tolerated by a healthy individual or a fit patient. Let's say patient is fit, posted for surgery or some treatment, but otherwise patient is fit. In those cases, the edema may be there, but patient usually tolerates it well. Whereas if the patient is elderly age group, belongs to elderly age group, and patient with cardiac diseases, these are the two important groups at high risk. They develop CHF and pulmonary edema if not taken care of during the intraoperative period or in the postoperative period, in just response to only a moderate volume excess. Even a moderate excess is there. The elderly patient and patients having history suggestive of previous cardiac disease may develop congestive heart failure, followed by pulmonary edema, and which is a life-threatening condition. So always the take-home message here is, whenever you are dealing with the fluid balance or electrolyte imbalance in elderly patients and patients with history of cardiac disease, be careful. Take every possible care not to give excess IV fluid in these group of patients. So that is all in this video. We'll continue. Till then, take care, stay safe. Thank you.